Fuchs syndrome, also known as fuchs heterochromic iridocyclitis or cyclitis, it is a chronic non-granulomatous. So it is a chronic and non-granulomatous condition. It is diagnosed at an average of 40 years of age. There is no gender racial predilection. Cause is uncertain. There is evidence that implicates the rubella virus. Signs in toxoplasmosis can be similar, and toxogondii has also suspected as a cause. It is possible that most of the anterior chamber activity is due to blood aqueous barrier breakdown rather than inflammation. Clinical features: the detection is often incidental. Findings are usually unilateral in 90 to 95% of cases. Symptoms: there is gradual blurring due to cataract is a common presentation, as are persistent floaters. Heterochromia may be noted, as shown in this picture. Heterochromia iridis is demonstrated most effectively in daylight, and in most patients the affected eye is hypochromic. Its quality is determined by the relative degrees of atrophy of the stroma and posterior pigment epithelium. So there is atrophy of the stroma and posterior pigment epithelium. It may be absent or subtle, particularly in brown eyes. In blue eyes, stromal atrophy allows the posterior pigment layer to show through and become the dominant pigmentation, so that the eye sometimes become hyperchromic in blue eyes. Posterior synechiae are absent except occasionally following cataract surgery. Anterior chamber shows faint flare and usually only mild cellular activity. Though exacerbations can sometimes be marked, the eye is virtually always white even during exacerbations. So this is about anterior chamber. The kinetic precipitates, they are characteristically stellate, as shown in this picture, and gray-white in color, located diffusely over the entire corneal endothelium. The iris nodules occur in 30% of patients. They occur on the pupillary border. They are called coepi nodules. Tiny crystals known as Russell bodies may be present on the iris surface. Iris atrophy: it is diffuse with loss of crypts. The iris appears smooth with a prominent sphincter pupillae and sometimes blood vessels. Pigment epithelial atrophy can be demonstrated by retroillumination. Iris vessels: fine irregular iris surface vessels are commonly present. Vitritis: opacities in the anterior gel may be dense. Posterior subcapsular cataract is extremely common, is shown in this picture. Posterior subcapsular cataract. Glaucoma is typically a later manifestation, but is occasionally present at diagnosis. Develops in up to 60% of the involved eyes. Several mechanisms are suspected in glaucoma. Gonioscopy may show fine radial angle vessels or small irregular peripheral anterior synechiae. The vessels are typically the source of the hemorrhage, sometimes seen on the incision into the AC during cataract surgery. This is known as Emsler sign, as shown in this these pictures. Fundus, peripheral choroiditis, foci, scarring have been reported. There may be an increased incidence of retinal dialysis. Macular edema does not occur except following surgery. Investigation. The diagnosis is clinical, though investigation may be necessary to exclude alternative conditions. Treatment. Long-term monitoring is indicated to detect glaucoma and other complications. Topical steroids may be used short-term for moderate to severe exacerbations, but are generally not thought to be helpful in the management of chronic low-grade inflammation. Cataract surgery carries increased risk of complications. There is poor mydriasis, possibility of post-operative hypema, increased inflammation, worsening of glaucoma control. Zonular dehiscence should be considered. Preoperative topical or systemic steroids are used by some practitioners. Glaucoma can be difficult to control medically. Surgical options include a glaucoma drainage device or trabeculectomy with mitomycin C enhancement. And last one is pars plana vitrectomy, may be considered for visually problematic vitreous opacities.